Okay, welcome everybody to this webinar, which is the first one of a cycle of webinars on CMT this month. The speakers are Filippo Genovese, who is the president of the European CMT Federation, the patient association for CMT in Europe. He's also the vice president of ICRA, which is the European CMT Research Association. We will speak a little bit about this later. And also in ACMT-Rete, which is the Italian PEG for CMT. He's the chief scientific officer and also the foreign affairs minister, as I say. And he's also a member of the EURO-NMD ERN, participating in the working group for peripheral nerve diseases. So welcome, Filippo. We are very happy to have you in this call, in this webinar.
Thank you, Davide, for the nice introduction. And let me thank both ERN, R&D and EURO-NMD, as well as EAN for organizing this wonderful cycle of conferences about CMT, webinars about CMT.
Okay, thank you very much, Filippo. It's a pleasure to have you in this webinar. And my name is Davide Pareyson. As you know, I'm head of the Rare Neurological Diseases Unit and of the functional department of rare diseases at Istituto Neurologico C.Besta in Milan, Italy. I'm also the co-chair of the EURO-NMD ERN Peripheral Nerve Diseases Working Group, and I'm a board member of the ECRA, and also involved in the PNS and CNTR. And this is the first webinar today, Challenges in the Diagnosis and Treatment of Inherited Neuropathies, particularly CMT. And the second episode will be next week with a talk given by Andrea Cortese, London and Milan, Progress in Genetic Diagnosis for Neuropathies. The third one will be given 1 hour later as compared to the usual time. It will be 5 p.m. European time, Central European time. Biomarkers and outcome measures for clinical trial readiness in CMT given by Professor Mary Riley, London. The last episode will be on current progress in CMT treatments given by Cleopas from Cyprus, usual time, and the last Thursday of January. So every Thursday we will have a webinar on CMT. This is organized by the EURO-NMD ERN in collaboration with several different organizations. I have, okay. That is the also rare diseases ERN, rare neurological diseases, the ECRA, the EAN, and also in some way the European Scientific Federation, ACMT-Rete, with Filippo, and also the CMTR, that is a special interest group of the Peripheral Nerve Society. And we will speak about the different perspective of the clinician and the patient in challenges in the diagnosis and treatment of inherited neuropathy. These are my disclosures. And we will have a very interactive session with Filippo. Every slide or every 2 slides we will speak, the two of us. And at the end we will be ready to have questions, take questions. Please use the chat, the Q&A, or even try to raise your hands, and probably you will be able to speak as well, thanks to Elizabeth. Remember that all the webinars are recorded and will be available later on the YouTube channel of the ERN website. So if you cannot attend it entirely, you will be able to follow it later. So with Filippo, we discussed which are the most important challenges for clinicians and patients and in diagnosis and treatment. We agreed that the patient odyssey to diagnosis is a great challenge, And the first step is how to get to the right specialists, and then how to reach the clinical diagnosis. Then another important issue is the genetic diagnosis. There are difficulties in obtaining it, difficulties in interpretation. There is a problem of communication between the clinician, the geneticist, and the patient. And it's important that the patient and the family understand correctly the genetic diagnosis and their implication. Then, after the diagnosis, or even without genetic diagnosis, care and management are very important. But who and how is still an open question. And there's a possibility of symptomatic treatment. There is no causative treatment thus far, unfortunately, but there are clinical trials planned or going or finished, and there is a great hope for this, but with challenges as well. And Filippo, every slide I let you speak as you prefer, and please feel free.
Yeah, this is basically the plan, because we've been with Davide, we've been brainstorming about the hurdles and the burdens which every patient encounters from the clinician and the patient perspective, and we got to this kind of walkthrough so we can go to the next step. For instance, the main goal and a significant goal of the European CMT Federation, which is a collection of a federation of patient advocacy group. Actually, it's not European, because we have many patient advocacy groups from all over the world, the States, China, Israel. So we're getting bigger and bigger. And as a result of the efforts of the former ACMT-Rete president, Daniel Tenes, who unfortunately passed away, and the vice president of the ACMT-Rete, Ingolf Pernisse, which is among the audience. Hi, Ingolf. In 2 years ago, in 2023, during the first CMT Specialist Paris conference, we thought that a great achievement would be to get together all the stakeholders orbiting around CMT research. So patients, clinicians, researchers, pharmaceutical companies, in order to join our efforts towards finding a cure for CMT. So the European CMT researcher was found, and this is the very first picture of the recently formed board of the CMT-Rete. But you can see all of us, again, clinician researchers and patient advocacy group representatives. So it was really a great achievement. So, and we hope and we will work hard along with ECRA to boost research and find a treatment for CMT.
Yes, this is really a very important achievement, and we are working hard to make this function, and we hope it will be very fruitful for the CMT community as a whole. Okay, this is also a very nice picture. I let Filippo to comment.
Yeah, sure. In Italy, we elected the penguin as the symbol of the CMT community because, penguin is wobbling while walking. Is kind of clumsy, at least on mainland. And I used this mascot to depict so-called patient journey from the very first symptoms to living fully your life with a patient empowerment and awareness of his condition. So there are many significant steps, for instance, the maze of doctors or the cold waiting room, which is actually a place where we wait for the diagnosis to be communicated. So this is a kind of a slide which actually we will gather all the topics that we will encounter today in comments.
Okay, thank you, Filippo. And so the first step is how to get to the right specialist, because, I mean, usually CMT starts early in life, during childhood or adolescent age, and less commonly during adulthood, or even sometimes very late in life, much less commonly. So the first to see a clumsy child because of CMT is usually the family pediatrician, or less commonly the GP. The first difficulty is, do they know the disease? This is very rare disease, not well known, so it's a problem of dissemination of the knowledge among physicians, and it's difficult to get the right diagnosis very soon. Another point is that because of the foot deformity and sometimes of the scoliosis, in other cases, the orthopedician is the first specialist to see the patient. And sometimes surgery is performed before the diagnosis, which is it's not very good, because the approach may be different in the orthopedic pes cavus, foot deformity, as compared to the CMT causative pes cavus foot deformities, because they may be treated differently because of disease progression. And so this is something to be avoided. Orthopedicians should know that the patient is affected by CMT before performing surgery. If there is no family history, the diagnosis is more complicated. And I've seen, particularly many years ago, many patients coming with the diagnosis of muscle dystrophy, Friedreich ataxia, and these occur much less commonly now, but differential diagnosis is still a problem. And there are patients whose symptoms are taken as circulation problems. Some others are diagnosed with acquired neuropathies and come to clinic being treated with IV, IgG, steroids. And others go to the physiatrist, which is a good choice, starting with the use of shoe inserts, ankle foot orthosis, and so on. And it's important to have somebody playing the game in the center position, that is the child neurologist for the CMT and the adult neurologist for the adult patients. And again, another issue is the transition from the care of the children to the care of adult, with all the implication. And usually the care for children is much better than the care for adult patients across Europe in every country. This is an issue. We are trying to work on this, but it's a long pathway to work on. Filippo, you may want to comment on this.
Sure. I will go briefly through every point. I have CMT1X, so I am a CMT patient, rather than advocating for CMT myself as a volunteer. So I was definitely a clumsy child since 2 or 3 years old, when I was 2 or 3 years old. So my parents started traveling all over Italy to seek for advice and diagnosis, and I got many funny sometimes answers, sometimes some fatal diagnosis. So having the GPs to know and recognize the basic symptoms of which might let the GP think about CMT is of paramount importance. In Italy, for instance, we have organized a free training course online for GPs to know CMT better, to know some of the symptoms of CMT. And we got almost 1,000 GPs attending this free course. So this is something we could work on, and this series of webinar goes in that direction. For the surgery, I totally agree with you, Davide, that surgery before the diagnosis is quite important. And I would say also the after surgery step is important, because in CMT, you should not let people stand still for a very long time, because muscle atrophy might not be reversible. So you should be able to put the patient walking, or at least start training, and rehabilitation should start as soon as possible. In my case, there was a family history, but actually I got a CMT1X, so my mother wasn't basically aware of this, because in my specific form, in female, the phenotype is not as heavy as in males. For the wrong diagnosis, yes, muscular dystrophy, ataxia, and other inflammatory neuropathies might be misdiagnosed as CMT, but it can be the other way around. So it happens that some people having CMT diagnosis then are actually diagnosed as ataxia or whatever. And for the transition, this is also an important step of the life of a CMT patient, because sometimes you feel like abandoned when you move over from the child neurologist to the older neurologist. So there should be a connection between the two of them to communicate and find out the best way to taking care of the patient.
Okay, thank you, Filippo. So education, communication, dissemination is very important issue, and thanks for all what you're doing as a patient association, and also what we are doing together. I think it's valuable and important to improve diagnosis and reduce the odyssey to diagnosis. Diagnosis goes through the clinical evaluation of the history of the patient, the family history, nerve conduction studies. It's important to perform it properly and evaluate the nerve conduction velocities and the amplitude of the motor and sensory potentials. The CMT may be demyelinating, primarily axonal. We have intermediate forms. We have sensory motor that are the most frequent, but also pure motor, pure sensory types of inherited neuropathy. So this is a central diagnostic tool. Then, after the clinical evaluation, the electrophysiological evaluation, we can go to the genetic testing. And sometimes other laboratory investigations are needed and may be useful for the diagnosis and differential diagnosis. Filippo, you stop me. I always leave you the
I
microphone.
mean, we can go through the way of diagnosis. I would just like to comment and say that having a diagnosis is important for many reasons. For instance, you must have a diagnosis to participate into clinical trials. It's also important for a psychological point of view, because when you have a diagnosis, you kind of know what will happen and what's going on to you. So it's kind of finding relief, finding answer, because otherwise you will always be tagged as the clumsy guy that can't run. So this is important. And third, having a diagnosis has also some implication in terms of legal benefits, economical benefits, job recruitment process. So it's definitely important to have a diagnosis.
Okay, thank you, Filippo. You described very well the importance of the diagnosis, both for clinicians and particularly for patients on different points of view. On nerve conduction studies, a few words. They are very important, but I mean, for children may be very traumatic, and I have seen many adult patients remembering as a nightmare the first and more than one maybe electrophysiological examination they had.
I'm one of them.
Yeah, I can easily understand, because it's so the advice is from the clinical standpoint is there is no need to repeat nerve conduction study too often, only where they are needed. Try to avoid the use of needles. Now you can have nerve conduction studies performed very well with surface electrodes, and the EMG examination, which requires needles, may be limited to very few muscles and only if relevant for diagnosis and follow-up. And I mean, the investigation need to be more extensive at diagnosis because it's important to have a whole picture and description of the situation before going to genetic testing. It's important for diagnosis. Filippo, you already commented with your experience that I imagine.
Yeah. I would just like to, well, we had a workshop a few years ago actually, and I made the same point, which is let's try to use surface electrodes rather than needles when it's possible.
Yeah. Okay. Then another very important and big issue is the genetic diagnosis with a lot of new possibilities, easier diagnosis, but also more complicated pathway. An issue is and was the time to get the response because the laboratory are often overloaded by work with a lot of requests, and the personnel is less and less. But on the other side, the technique are improving, so we are able to have more responses in a fewer time on the other side. Communication of the results is critical. It's a very important point. What does this response, genetic testing response for the patient, for the family? We, as a clinician and geneticist, need to be very clear in communicating the results and try to avoid that the response goes to the patient without a concomitant explanation. And because sometimes it's very complicated to explain the situation, how certain are we of the diagnosis? What is a variant of unknown significance? Which is the prognosis after this genetic testing? Sometimes it's easy to explain, other times it's very complicated, even for the neurologist to have the clear picture of the situation, because these are rare diseases. Some genes are very, very rare, and the mutation differs. Of some variant, we do not know if they are pathogenic or not. And then we have the genetic counseling, pre-symptomatic test, and planning for pregnancy. We can speak about it later. I suggest I comment on a couple of slides, Filippo, and then you go.
Sure.
If it's okay for you.
Sure.
Because one problem is that, I mean, we know much more than a few years ago, but this is a still incomplete list of the genes associated with CMT and related neuropathies. And now they are listed to be 125 at least. So we have many different types of CMT. They can be similarly clinically, or there might be some differences, but the list is very long, particularly for the axonal type. We are going now from CMT to A to CMT to Z, and now we are using the double. And so it's a very complicated classification, difficult for us, I can imagine, for the patient to understand. Some genes are much more frequent than others. That's easier because we know better the disease, we know better the mutation, but in other cases, it's quite complicated. So it's important in the genetic testing, as I told you before, to define the phenotype that is based on the clinical presentation, the family history, the inheritance pattern, the nerve conduction studies, and sometimes other diagnostic tools. Then the molecular test is performed. Once upon a time, we used a single gene approach, gene by gene. Now we use next generation sequencing. That means that you can have a test including all the known genes for CMT, that there is a panel of the majority of CMT genes. Now, more frequently, we are using the whole exome sequencing that implies to investigate all the coding genes that are a few thousand, some thousand, or now more recently, mostly still for research, whole genome sequencing, that is sequencing the whole genetic genome, all the genes and all the sequence between genes. That is a lot. So you can imagine that the answers can be very complicated. If we are lucky, we have a definite diagnosis. We find a already known mutation associated with the phenotype, the clinical presentation of the patient. Everything is concordant, and so we have the diagnosis. In other cases, we found no mutation, and this happens. We will see how often later. The most complicated situation is when we find variants in the genome, in the CMT genome, in other genes, and we do not know the significance because not all variants are disease causative. We are diverse, and my genes are diverse from those of Filippo. Even normal genes may have many differences. So it's difficult to establish whether what we find in these approaches is really the cause of the disease. This is the most difficult situation. There are some tools we have. We estimate the frequency, the population. If it's very frequent, it's probably not the cause of the CMT presentation. We examine the behavior of this variant in the family, affected and unaffected patients, subjects of the family. If unaffected family members carries this variant, probably this is not the cause of the disease. Vice versa, if we find that all affected subjects carries this variant, this gives strength to the observation, but it's not certainty. That's the problem. So we examine if this variant is conserved across species. So if the site of the variant is important for the gene, which is the mutation type, there are programs to predict the consequences of variants, and also there are the possibility of performing functional studies. So it's not a yes or no, it's a composite, complicated situation where the answer is a statistical probability. So this is very complicated, maybe very complicated. And then we go back to see whether the presentation of the diseases can be in agreement with the type of mutation we find. So it's just to say that it's very complicated. And before Filippo comment, this is the experience of the London Center, UCL, Queen Square National Hospital, which is the most advanced center in genetic diagnosis currently, and very, very advanced. Through genome, whole genome sequencing, that is the most advanced tool. Still, for overall inherited neuropathy with the CMT type, we do not find the diagnosis for almost 1/4 of them, even in London. And particularly for the axonal type, for the pure motor type, and also for the sensory types. And so there is still a gap. We do not know how to fill. There are studies ongoing. We will improve, decrease, but this is still an issue. So it's not possible to have the diagnosis in all cases. And Filippo, you're free to comment. And
yeah, well, as you depicted, the picture is quite complicated. So trying to get a response might not be, this is something we have to explain very well to people, because if the mutation is frequent among the population, you might get a response, a hit in a few weeks or a few months. But if that gene has not been yet, for instance, described, this might be even trickier or even impossible to be diagnosed as a CMT. So we invite people to be patient about getting a genetic diagnosis. It's not just a matter of lack of staff or lack of time of the laboratory, but sometimes it's really tricky to get a response. For the second point, the communication of the results, yes, this is something that all the genetic laboratories and neurologists should work on, because yeah, it happens quite often that people get this weird letter by email or even post, and they find this strange names and figures. They don't know how to work it out. So a lot of frustration comes in, and people ask the doctor Google about the specific disease, and this turns even more dramatic. So it will be better to have genetic counseling and communication of the results in a very easy way. And yeah, this is particularly complicated in the case of variants with unknown significance. And yeah, genetic counseling is also a matter. So having a diagnosis means also that I know if I have a project of building a family, of growing a family, then I know what could happen to my kids. And there are some methods out there to prevent passing CMT to your relatives, to your sons, if you don't want to. For the pre-symptomatic test, it's a real debate between patients and neurologists. I don't know whether Davide would comment it. I'm not biased towards it, because I understand that you tend to protect the kids before they develop any symptoms, since as of for today, there's no curative treatment. Is that correct?
Yes, it is correct. In Italy and also most countries, you cannot perform a pre-symptomatic test in a patient who has not reached the age of 18 or major. In a minor, you cannot do unless he or she present symptoms that may suggest the presence of the disease. In this case, there is no problem, but otherwise it's not allowed. And it occurs, it is done, it shouldn't be done really, because I mean, you go beyond the right of the child. He has the right to decide when he reaches the age of 18. And yeah, I can understand perfectly the anxiety of the parents. Absolutely.
Yeah,
So
the risk is that they become overprotective, that tend to protecting from and preventing from doing any physical activity. So it might be fit to, let's say, cycle or whatever, but they might tend to overprotect him. So this could also affect the development, the growth of the kid into a young man or young woman.
Yeah, yes. So there may be, I mean, we usually suggest to have not too anxious observation. It depends on the parents' habit, attitude. So it's individualized. And if there is some symptoms immediately, we suggest to go to the child neurologist. There may be some tool to get to diagnosis without genetic testing. That is, for instance, in CMT1A, the nerve conduction velocities are reduced since very early in life. So one nerve testing can be enough to assess the median nerve on the lower limbs. If you have just one nerve conduction study, so even the ultrasound exploration, you may suspect the presence of the disease, and then you're allowed to go to genetic testing. So there may be some compromise that
Exactly.
it depends, yes. Genetic counseling is absolutely important, yes. And planning for pregnancy, we now have an increasing number of affected subjects that goes to planned pregnancy with the pre-implantation diagnosis. This is allowed in most countries, and the technique are increasingly improving, and it's in Italy there is a long list for the national health system, the waiting list, and so it's quite costly if you don't have the time. So it's again quite complicated.
Yeah, and it's not 100% safe and sure that you will
absolutely
pass.
Yeah,
so there's still a little margin that we do have cases in our association of a young woman who passed it CMT-1A to his son. Her son.
This is very unfortunate. And also there is, I mean, some risk for the mother because there is hormonal treatment and the mini invasive procedures that in any case stress. So it's not easy.
It's important to choose the right genetic diagnosis laboratory.
Absolutely. This is fundamental. And I advise to go to an expert and if possible public ones. Yeah. Okay, we agree, Filippo.
Yeah, it's definitely worth waiting in this case, because if you go to a public laboratory, you will get, let's say, a higher degree of certainty.
Yeah, and protection as well. Okay. Yes, because it's becoming also a business in some way, so we must be careful. Other steps with Filippo, we designed this importance of care and management, rehabilitation, surgery, management of pain, healthy lifestyle. Filippo underlined the importance of this. If you may comment.
Yeah, sure. We're running short of time, so we might fly over the next slides.
No, we have not many slides, so we have time.
But just to comment, all these steps would want to answer to the question, is there anything I can do? So the answer is yes, there are many things patients can do, even though there is no curative treatment at the moment. Davide will go through it in a few slides. But we can also partner in the research and advocate, and so contribute to the activities of the association. And this is quite important to have every patient as a partner in this process.
Yeah, absolutely. This is very important. Even sometimes in the clinical trial design, it's important to take into account the patient experience. In clinical trials, we are trying to use now patient-reported outcome measures. That is the patient perspective. This is very important. There is symptomatic treatment, and many patients complain of pain related to the foot deformities, the osteoarthromuscular problems. Sometimes it's a true neuropathic pain. Fatigue is an issue. Sometimes mood disorders, because a chronic disease causes an increased rate of anxiety and sometimes depression. Pregnancy is a particularly delicate phase of the life of CMT patient. Rehabilitation therapy is important. The use of orthotics aids. Surgical therapy, we will touch this, and there is a list of drugs to be avoided. But it still happens that some physicians tell to the patient there is nothing to do. This is entirely not true. This is an example of a lady in the 50s who was protected too much from the mother, and with CMT1A, with preserved strength in the lower limbs, but foot deformities untreated became dramatic and preventing normal gait in a very, very hard way. In this case, physiotherapy, stretching, maybe surgery would have changed completely the life of this lady. So this is something that we shouldn't see at all. Rehabilitation is important. This is unpublished material we are working on from the registry, National Register of CMT in Italy, which is funded by Teleton and with the collaboration of the ACMT-Rete, the PEG. We see that many patients receive physiotherapy at least once, about one half, more than 3 or more cycles. Seems to be effective because 62% of the patients were satisfied, at least 6 out of 10 on a VAS scale. You see in green the degree of satisfaction here. The problem is the benefit is not lasting, 1 to 3 months in more than one half the cases, but after 6 months it's almost always disappearing. So this underlines the need for either repeated cycles or continuous physiotherapy. It's a problem because there is, for certain difficulties in accessing physiotherapy, this was perceived by almost one half of the patients in our series. It was before COVID, because this is not very recent data. It worsened after COVID. And so this is a real issue in Italy. There are regional differences. Some regions working better than others, but and I know it's a problem also in other countries. This is a real problem because physiotherapy is important. And Filippo, you may want to comment.
Yeah, I totally agree with you. Yeah, access to physiotherapy is something we have to advocate to everyone in every country where a CMT patient advocacy group is operating. So we should ideally have a dedicated rehabilitation plan which covers continuous intervention all over the year.
Okay, this is just to say that there are different types of orthotics. If you are not comfortable with one, you can try other. So do not stop to the first one. It's important to discuss with the physiatrist and the physiotherapist the correct approach. There are IGFO, a plastic, elastic, high or low WFO, and so on. This is again published data showing that for anchor foot orthotics, 70% of the patients have some complications, some side effects, ulcers, reddening, calluses, pain, and leading to abandonment in a significant percentage of cases. And so this is our experience in the about 10 years ago. 21% prescribed AFOs were never used, were almost 1/3 abandoned, 70% of complications. So there are ways of improving this data, and it's important to have appropriate prescription because it must be individualized for the patient, and early customization important. There are now different manners, including 3D printing and use of computer to define the foot deformities that can allow better preparation of orthotics. Filippo, you may want
definitely.
to comment.
There are also some AFOs which are produced by making a 3D scanning of the ankle and foot. So these kind of issues might not be present in our case. And I would also mention that there are some shoes which are AFO friendly. so which allows the patient to wear the AFO and in a better and more comfortable way. But yeah, AFO are an issue. I mean, our lockers are full of shoes and AFOs we don't use anymore.
Okay. We are running short of time, so I will go faster. I mean, the foot surgery is another issue. There have been workshops to decide what to do, because there are different approaches depending on the surgeons. But there was an agreement of what not to do. That is easier than recommend what to do. In any case, the aim of surgery is to align the foot, to make the foot in the proper position. A plantigrade foot is the most important of the surgical goals. So surgeons may have different way of reaching this goal, but this is the main goal. And bracing, orthotics, etc., help to manage other types of deformities or before surgery they may be useful. Filippo, you may want to comment.
Sure. I totally agree with it. I would add on the top of that that functional surgery approach should be used. I mean, not a receipt for every CMT foot, because our feet are all different, but trying to find whether there is a way to recover some abilities and not worsen the things any further. And I was, as I mentioned before, early rehabilitation after surgery is recommended because otherwise we will lose our muscles and we might not recover them even with heavy rehabilitation.
Yeah, quick mobilization is important. You may want to comment here.
Sure. This is something we made at a national level, which is recommending a center of excellence for care, clinicians, physiotherapists, and AFOS manufacturers all over Italy, just like in the database for Orphanet for the clinicians, for instance, which is available online, but we integrated it with this further information.
Okay, this is very important also. We need to go fast, but this is just to say that there are a long list of contraindicated drugs, but in this analysis, it appears that only a few are really contraindicated or must be used with great care, that are chemotherapeutic agents, and otherwise there is little risk for any drug. Although it's good to have a discussion with neurologists if you're going for long treatment. Therapy, there have been a lot of advances, and now we are speaking about preclinical experiments with gene therapy, with gene silencing, with pharmacological drugs. We are seeing the light at the end of the tunnel, but there are still a lot of obstacles. And this is the summary of the different approaches we have on the pipeline to treat demyelinating neuropathies, axonal neuropathies, different site of targeting, drug targeting the different part of the nerves. We have 2 or 3 slides more. Just a list of the most promising, but also with challenges. The silencing of the PMP2 gene is a good strategy for CNT1A. A trial is under preparation, although the cost-benefit ratio is still to be better understood. The PXT3003 in CNT1A, unfortunately, the trial was negative, but there is also a trial in China performed. We are awaiting publication results. CMT SOD is a metabolic CMT type. There is interesting drug for treating it with a phase 2 trial performed. Now we are waiting that this company producing Govarstat will be acquired by Cycle in February. We know what will happen. Serin for hereditary sensory neuropathy type 1 in UK, another completed trial. There were challenges in recruitment, showing that is running a trial in a very rare disease is a challenge. And there is another compound targeting the chloride channel in CMT, and we are waiting for the results of the phase 2 trial. Gene therapy is a very important hope, but with problems occurring in other trials with Duchenne, with amyloid neuropathy, and also a couple of trials in neuropathy are there is no further news about it or no further planned trials. So it's a promise, but there are a lot of challenges ongoing, and this is the list of problems we long time for clinical studies to the market. Only few drugs reaches the clinical trial phase. Long duration of trials, difficulties in outcome measures. Small companies are highly dependent on investors, and money allowance drives the trial design. But it's important for us and also for the patient to give advice. And Filippo, you may want to comment on
just
on
two quick comments about the outcome measure. I invite all of you to attend the Neurology webinar. I mean, this is quite frustrating that we get drugs that are that close to the market, and then for some reasons they are not, because thanks God, CMT is slowly progressing, but this means that we need to have some tools which are very, very sensitive to appreciate any improvement that the drug, that the treatment might cause compared to the control group. So this is really tricky. And so everyone, it happens quite often on social media or even on email, complaints about we want to cure. Yes, that's true. We are all working in that direction, but we do want that any treatment that might be selected must first of all be safe for the patient. So no need to rush. It's okay to wait, or at least to leave the science the right time to prove that a treatment is safe before going on.
Yes.
And in this case, I will comment this slide briefly. Patients and patient advocacy group is quite important. You see a picture from a bunch of us from all over the world during the last conference in Antwerp. So we do collaborate with research. We promote and support the participation in clinical trial. We have to provide feedback to improve therapies and trial design. This is quite important to discuss with the clinician, and many of us are part of the scientific advisory boards of some trials. So we do provide the patient feedback, facilitate communication. We also advocate for funding and supportive policies, and we interact with the regulatory agencies as well, and this is quite important. And first of all, last but not least, we empower patients to engage in care and research.
Okay, great. That's okay. This is again the penguin game, and this is the acknowledgement to all the supporters of these webinars. And remember that for therapy, we have a webinar on the last Thursday. Biomarkers outcome measures will be dealt in here, genetic diagnosis. So there is still room for discussion of these topics in other webinars. We have time for discussion. Not much, sorry. I'm sorry for this.
Yeah, there's a question on Q&A.
Yeah, I see also in the chat.
Yep.
There is There is okay. Okay, this is the okay. From there are personal questions you can write me directly through the ERN or through the directly the Brexit. I don't think it did affect the UK research involvement too much because we have a lot of collaboration with UK and there's a geneticist from Ecuador seeing patients and making diagnosis. Using botulinum toxin, we don't use it usually. There's somebody using it for particularly for food deformities. It may be useful, but it weakens the muscle, so it must be used with care and in expert hands. So we don't use it too much. There was somebody with some problem. Okay.
Yeah, no more question, but one in the Q&A. I have HNPP and severe symptoms, pain, meds don't work. What else can I try?
That's the problem. HMPP, the first advice is to avoid compression of the nerves. And for pain, the treatment is that of the usual pain treatment that is with drugs for neuropathic pain. It depends on the type of pain, or anti-inflammatory drugs, or physiotherapy is important also for treating pain and stretching against cramps. So there is some possibility to do, but it depends on the individual situation. We are ready to answer to other questions, if any.
Yeah, there's one from Luigi, which asks any news about the SOAR trial.
Oh, SOAR trial, we are waiting news in February because Applied Therapeutics was acquired by another company based in UK, US. We are on hold waiting for the decision of the new company. We hope very much to be able to perform a phase 3 trial, but we are waiting. The drug is promising. We hope to be able to perform a trial.
Yeah, we're in close contact with patients as well, so we'll keep you posted about this.
There is a question. Do you think that AI can improve the diagnostic challenges in the future? I believe yes. We performed a study with colleagues from several countries comparing the ability to diagnose 100 hypothetical cases, including genetic cases, from a specialist in neuropathy, a non-special neurologist not specialized in neuropathy, and AI. AI performed in the middle. That is, the specialists in neuropathy are still the best, but AI may improve the diagnostic rate for non-specialist neurologists, not specialized in neuropathy. So there is a role.
Yeah, I can remember about the work which was presented during the last BNS about using AI for interpreting MRI images. So this could also be something.
Yeah, absolutely. And also for the genetic, interpreting the genetic results, there are tools that solve.
There is a ongoing project which is called Compass NMD, which is actually using AI to drive the diagnosis processes in many neuromuscular diseases, including CMT.
Okay, so the answer is yes. So restless leg, it depends on the cause. If it's central, pramipexole is a good drug, low dose, but in peripheral neuropathy, usually it's not useful. If it works in within a week, so it's very easy to test it. Bedtime, one pill, 0.18 milligrams can be helpful. Otherwise, it's more complicated. Gabapentin may be used with depending, variable results. Okay. Filippo, help me if you see any other question.
No, I don't see any questions. So it's time to say bye to everyone, and thank you for attending the webinar on my side.
Okay, yes, okay, perfect time. It's 5 o'clock. So thank you so much to the audience, to those who will follow the webinar afterwards. To Filippo, it was incredible to have such a nice discussion, sort of ping pong
My pleasure.
game, yeah, with the penguin game. So thank you all. Thank you, Elizabeth,
Thank you, Davide. Thank you, Filippo. See you next week.
Next week, same time
Yeah.
for genetic. Bye-bye.
Bye-bye.
Thank you all. Bye-bye.
Bye.